Hi everyone, my name's Kelly. You might know me as one half of Two Humerus Nurses. Jackson from Nurse Break has asked me to jump on today and talk to you about what is an oncology nurse. I've been a nurse for 20 years, spent the last 5 years working in an oncology medical day unit. And an oncology nurse basically is somebody who works with cancer patients to give them chemotherapy and other supportive treatments. How did I become a oncology nurse? Well, kind of fell into my lap. I started work at a new hospital and they were opening up this oncology day unit and I just applied. I had to go and do a training course to an oncology chemotherapy nursing course, and then a couple of weeks of practical placement in a bigger facility, just to give some chemos and access some CVADs and just get my skills up before we started. Yearly I do a refresher course on EverQ for the ADAC modules, and I do that every year, and I also do some courses through the Peter MacCallum Cancer Centre in Melbourne and some other big hospitals down there, just to keep my skills up, because cancer is an ever evolving nursing field and the changes in treatments are happening all the time. So it's good to keep on board. And a lot of our patients go away to Melbourne to have bigger treatments like stem cells and things, and it's good to know what they're having and how, so I can manage it at my end as well. What type of patients do you care for and what is your role in their care? So on a treatment day, we have all our cancer patients come through and we provide chemotherapy, immunotherapy, and that can be IV or subcut, which we're doing a lot more for our hematology patients. We also do CVAD care and supportive treatments for patients like blood transfusions or things like that. I have two roles, so obviously I'm a chemotherapy nurse, but I'm also a cancer resource nurse. So I provide follow-up and ongoing survivorship support for patients who have finished their treatment for however long they need afterwards. I also run a cancer wellness and exercise program, along with our dietitian and exercise physiologist at our workplace. That's a program for people who are in the survivorship phase, just to provide extra support on what to do after they finish treatment. So I sort of cover all areas and all stages of the patient's treatment. That's the benefit of working in a small unit, I guess, is you're there from start to finish. What does a typical day look like for you? So our weeks and days change every day. There's no day that's the same, which is something that I really enjoy. So when we start the day, we come in and have a look at the appointments. We plan out what chairs we're going to put people in. There's only 2 of us that work on the floor in my unit. So we work like a little team, and we don't take patients' load. We just work together. We set up their equipment that they're going to need, their lines and whatever fluids they will need, and check their paperwork. Usually prior to the day, I would have done some following up of their blood work, sent that off to the medical oncologist to make sure that they're okay for treatment. And then when the patient comes in, we do a full assessment on them to make sure they don't have any toxicities or side effects. If they do, then we will notify the oncologist and have a chat with them over the phone and see because we don't have any doctors on site. We're a nurse-led clinic, so there's a lot of assessment, and we have to base it on how we my dog's barking, on how we assess the patient. So we will always discuss with the oncologist if the patient's not well or if they're not right, and then we get the go-ahead whether they can have their treatment or not. Then we cannulate, do OBS, get them ready and start their infusions. In that time, we're also, checking in on them, making sure that everything's going all right. If they need any extra support, we would have checked their weight, and we work really closely with the dietitians at the facility, because malnourished or like malnutrition in oncology patients is something, it's a key performance indicator. It's something that we need to keep on top of. We don't want our patients to be losing weight. So we work really closely with them. We just see if they need any extra help, any extra referrals that they might need. And yeah, by having conversations with them, we can gain a lot of information. And then they have their treatment. We pre-book everything for the next however long for their next few appointments. And then, yeah, usually in my role, I follow as a cancer resource nurse. If they're new, we'll follow them up a couple of days after treatment to make sure they're okay, and that everything was all right. And we could do anything in a day. We do chemotherapy, we do blood transfusions, we do iron infusions, we do IVIG, which is immunoglobulins. We do lots of outpatient stuff. We can do venesections for hemochromatosis, CVAD care. It changes all the time. So it's going to work. You just never know what you're going to get. Even though you know exactly what's happening, it can change. What is it? Myths or common misconceptions? I reckon the biggest myth that I come across is that people think oncology is sad, that it is a sad place to work. And people always say to me, I don't know how you do it. It's not sad. We have so much fun. I think that the situations that our patients are in, they make difficult decisions. They have difficult conversations regularly with their doctors, with their family. And so when they come to us for treatment, we try and make that a really upbeat, light-hearted time so that they don't feel like they're strapped to a chair getting poison pumped into them. We have quite personal relationships with our patients. Some of them we see weekly for years. So we know what they like. We ask them about it. We share stories. We chat about our favourite podcasts, our favourite TV shows, what books we're reading, what have we cooked. We have conversations, and we like to keep it lighthearted and have a joke and, make it a fun time for them to come in, especially in the last 18 months where visitors haven't been allowed to come in and we're their only source of comfort. I think they look to us for that. What's something you wished you knew before you started? Oh, I think I wish I just knew how much I would enjoy it, because at the start I really struggled. But 5 years in, I'm loving it. So sometimes you just got to stick with things, I guess. Challenges and negatives, I guess. With COVID, it's been really hard to have these face-to-face discussions with oncologists. Everything's been done by telehealth. So I've had to be really supportive for the patients and have conversations with them that normally oncologists would have. Because whilst they're on the other end of a video, I'm in the room with them and they look to me to explain what the oncologist is saying rather than onto the, the screen. So this last 18 months has been it really quite challenging to learn to have those conversations with patients in a way that is from my scope of practice as a nurse. Like, I'm not supposed to tell them those things, the doctor is. So when I'm in the room with them, I have to redirect them back to the doctor. So that's been really challenging. I mean, some of my patients haven't even met their oncologist face to face. So it's just a different time, really. How do we deal with death and dying? So that's obviously a big part of oncology nursing. Like, our patients either live or die. Like, there's no in between. Some of them know that that's going to happen and that's going to be the outcome. Some people are really okay with dying. Some people aren't. You know who you can talk to and who you can't. My biggest thing is that I talk to them about advanced care planning, about documenting their final wishes so that we all know what they want, and doing it with their family present and having conversations with their family. We also get community palliative care involved really early, so they have support at home as well. I personally believe that it's a privilege to be with someone while they're in their final stages of life. I mean, most people live amazing lives. So I believe that you deserve to have, a dignified death. And I think it should be as pain-free and as comfortable as possible. Now that I'm in the oncology day unit, I don't often get to spend a lot of time on the ward in the palliative care side of things. So I leave that to my colleagues, and I take a step back, and I will go down and say my goodbyes to the patient, and then I wait, because my role isn't to be on the ward. I just take that step back, and it is sad. Don't get me wrong, some of my patients I've been devastated about losing, but you see how hard they fight. I see how hard they fight, how hard they work to stay alive. So when they die, you know they've done everything they could. And I think that's really special. And I don't think we should be scared of dying and death. I think we should talk about it openly, and it should not be taboo. And that is something that I'm trying to change. And I'm trying to start these conversations early in a really comfortable, non-scary way to these patients. And it's been quite well received lately. Unique pieces of equipment or skill that you use in your area that other nurses may not know about. Probably CVADs is the biggest thing. And I think if you can become CVAD competent, you will be invaluable, because my patients will go to the ward and they will have no idea what to do. And PIC lines, TVADs, or ports, they've just changed their name to TVAD, they're game changers. Like, you don't want to be fishing around for an IV in a patient that might only have one arm because they're a breast cancer patient, or, and their veins have been shot over the time with all like chemo and CT contrast. You want to get it in. So a port is amazing. Like, don't be scared of ports, just go for it. And PIC lines are great too. They obviously come with a level of complication and extra care, but I think if you can get your head around CVADs and get yourself some competency in that area, go for it. There's a great learning module on EverQ for CVADs. Tips for students or grads in your area. So recently we've had both students and grads come through our department. Learn, you're not going to learn a huge amount up front. I mean, you're going to learn a lot, but there's not a lot you're going to be able to do. You won't be able to hang chemo or anything like that. But ask a lot of questions. Ask questions. Try and get your CVAD competency in while you're in those units, or your IV cannulation. There's so much to learn in that area. Sitting in those difficult conversations that are being had. If you can get in, have a seat with the oncologists and while they're having their appointments, it's great learning. I know a lot of people don't want to share that, so you just need to ask permission first. But don't be scared. Don't be scared to talk to the patients. Ask them about their cancer, what they've been through. Most of them are more than willing to talk to you. So I would definitely, jump in. I think that's all the questions, but I just want to say oncology is amazing. You should definitely look into it as a specialty, especially if you don't want to do shift work Monday to Friday. Can't go wrong there, can you? And if you have any questions, just shout out, because I'm more than willing to have a chat about it. It's an area that I've fallen in love with. I think we make a big difference in people's lives, even just by doing the smallest things. So I want to thank Jackson for and the nurse break for asking me to jump on and have a chat with you today. And hopefully I'll talk to you soon. Bye.